My topic is clinical outcome following interlaminar endoscopic discectomy versus microdiscectomy at the level of the L5-S1 disc prolapse is a propensity measured analysis. As we know, the incidence of the L4, L5 disc is 49% and the L5-S1 is 45.2%. Microdiscectomy is considered the gold standard and endoscopic discectomy is now gaining the popularity. At the level of the L4, L5 and above level, transforaminal is better, but at the level of the L5-S1, the interlaminar is better due to direct approach and wide interlaminar space. The transforaminal is challenging at the L5-S1 due to elevated iliac crest, angle of the sacral inclination, foraminal anatomy, and hypertrophic transverse process. This is the meta-analysis of the 7 studies. They mentioned that the endoscopic discectomy is better result when compared to the microscopic discectomy. They also, the 192 patients with 2-year follow-up, they mentioned the VAS score for the low back pain is significantly better in the endoscopic group. In other meta-analysis, they mentioned the endoscopic discectomy is shorter hospital stay, but they also mentioned the higher incidence of residual disc or incomplete decompression. The aim of our study is to compare the clinical outcome between patients who underwent microscopic versus interlaminar at the level of the L5-S1 with minimum 1-year follow-up. It is a propensity measured analysis with a total 100 patients, 50 in the microscopic and 50 in the interlaminar group. The inclusion criteria are the patient who had age between 18 to 70 years with a unilateral radiculopathy and minimum follow-up for 1 year. The exclusion criteria are the patient who saw the radiologic evidence of spinal instability, multi-level surgery, and previous history of spine surgery. What is the propensity measured analysis? It is a balancing score in which we distribute the measured baseline covariance is similar between both the treated and untreated patient. The most common method is the 1-to-1. The clinical outcome in the terms of the VAS score for the back pain and the VAS score for the radiculopathy, and the functional score in the ODI score and the SF12 scores. In microscopic group, the mean age is 39 years, and the endoscopic group, the mean age is 38 years. If we see in the post-operative period, the VAS score is significantly different both in the endoscopic and microscopic. But at the 1 year, there is no significant difference in both the groups. For the radicular group, for the post-op, the VAS score is no significant difference in the microscopic versus endoscopic. The ODI score, we see the post-op in the significant difference in both the groups, but at the 1 year, both are the same. There is no significant difference in the SF12 scores. In this discussion, we found that in initial 3 months, the reduced post-operative back pain, faster recovery, and improved functional outcome in the endoscopic group. But at the 1 year, there is no significant difference in both the groups. We also found that the numbness is the more common in the endoscopic group. The maybe cause of some studies show that the patient with longer preoperative symptoms have more numbness in the post-operative period, and central disc prolapse show the more the numbness if compared to the paracentral foraminal disc prolapse. The discussion that a limited visualization, constant operating space account for a longer learning curve, and the common operating include the overuse of cautery and inadequate nerve root detection for assessing the disc space. The endoscopic discectomy provides faster post-operative recovery and can be done as a daycare procedure. Inadequate decompression is a potential pitfall and should be avoided.